So hello everyone. We are very, very pleased to have all of you join us today for this session on preventing falls and also strategies for healthy aging. My name is Shu Hui. I'm Medical Director from Angsana Health, and I'll be moderating our discussion today. So our discussion today will focus on one of the key strategies for healthy aging, which is to avoid falls. So this evening, we are very, very honored to have with us Professor Tan Mau Pin. She is Professor of Geriatric Medicine at the University Malaya Faculty of Medicine. Prof. Tan is an esteemed expert in geriatric medicine with a commitment in improving the health and well-being of older adults in Malaysia and also beyond. She was trained in the UK and then went on to hold an academic position at since 2011, where she established the Falls and Syncope Service at the University of Malaya Medical Center in 2014. So Prof. Tan is also co-founder of the Aging and Age-Associated Disorders Research Group and was the principal investigator for Malaysian Falls Assessment and Intervention Trial and also Life After Fall study. Prof. Tan was also part of the steering committee for the World Guidelines for Falls Prevention in Older Adults. So there really is no one better to talk to us about falls prevention. Thank you very much for your time, Prof. Tan.
Thank you very much. Okay, I'm just going to share my slides.
Yeah.
So thanks very much for this opportunity. I never turned down an opportunity to talk about falls prevention because it's probably one of the most misunderstood conditions that for humankind. Yeah, so misunderstood. Yeah, so first of all, can I just get a bit of audience participation? Okay, who amongst you is actually a healthcare professional? Can you put up your hand or put up or type in the chat just to make sure that you're awake?
So if you're a healthcare professional, you can raise your hands. Or I think we have quite a few.
Oh, okay. Oh, good. Nigel's not a healthcare professional. Excellent. Yeah, because this talk is really aimed at the public. Healthcare professionals, if you really want to learn falls, you actually have to come on the courses. And we actually have something for you later. But it's good that you've joined also because it gives you a taster of what falls really is like. So I'm going to start my talk now. So falls prevention. Okay, so everybody thinks they know what falls is. And sometimes when you talk to the doctor, they're like, easy what? I just tell the family members, don't let them fall again. And that's the sum total of the intervention for falls. So it's an assumption that the people fall because the adult children let them fall. Older people fall because the adult children let them fall. And people usually assume that you fall because the balance is bad. So I'm going to hopefully dispel these myths in the next 30 to 40 minutes. But if you have any questions at all, please do just type them in the question and answer section immediately. And I will either answer it there and then or leave it until the end of the talk.
Yep.
Okay, so falls are very common in older people. So how common are falls? And you might be surprised to know that if you are over the age of 60, you have a 1 in 6 chance of falling in the past year. That is if you are a Malaysian. Now, this statistics is actually far less than international statistics. So usually when I do a talk in an international talk, I will actually say 1 in 3 older adults fall at least once a year. We don't quite know why Malaysians are less likely to fall. It could be that only half of them will tell you that they've fallen because the other half are hiding the information because they will have the liberty taken away from them. So they conceal falls. Or the other thing is that our older people maybe are less active and more watched and more prevented in being physically active. And therefore, if you're not active, you don't fall. So, but it doesn't mean that it's good for you. Okay, so here we go. So why do our older adults fall? So this slide actually shows the 3 most common reasons why older Malaysians fall. And when you look at the published research, there are actually hundreds of reasons why older people may fall. And most of the reasons are quite common sense. So if you cannot see properly, you fall. If the floor is slippery, you fall. So in places like I was watching a documentary about Norway, and they actually had these interventions to get older people out of their homes. Why? Because in the winter, they all stay at home because the floors, the ground outside is ice. Yeah, very slippery, so they don't go out. So they actually have these initiatives to actually make the outdoors much safer for older Norwegians, so they are not having to skate across their pavements. And so having an environment that is not good increases your risk of falls. But the most common cause of falls in the older Malaysian is actually the medications that they are taking. And this came as a surprise for us when we did this study. But it's no longer a surprise because other people then repeated their study and they found a similar thing. So if the study's done about 20 years ago, actually made the conclusion that it was actually poor balance that increases the risk of falls. That's the most common reason why older people fall. But over the past 2 decades, the number of medications that older people take now is really very many, and it's almost unavoidable being an older adult to have to take many medications. And unfortunately, some of the medications that older adults take regularly do increase their risks of falls. Don't panic. Don't think, oh, I must stop taking all my medications, because we'll go through this in a little bit. Okay, but so that's 4 out of 5 older adults who fall actually are falling partially because of their medications, partially or possibly falling because of their medications. Then unsteadiness is quite common. So if they have poor balance or they can't walk properly, so we call that impaired gait and balance, then they are more likely to fall. And this risk factor is actually present in only 3 out of 5 fallers. So if you think, oh, you fall already, send you to physio, that's the end of the story, then you're actually not going to solve the problem for 2 out of 5 people straight away. Then low blood pressure. Now, that's very closely linked to medications, because the most common drug taken by our older adults is actually blood pressure medications. And while blood pressure medications are taken to lower your blood pressure, sometimes as you get older, your body changes, so the medications become too strong for you, or sometimes as a side effect of the medications, your blood pressure drops too low when you stand up, or when you get up from sitting or lying down, or when you stand up for too long. And this low blood pressure is extremely dangerous, because if your blood pressure is low, you're not getting enough blood to your brain. And therefore, at that moment, you can be very unsteady and your brain is not thinking straight. And the risk of falls can be very high. And the injury that results from the fall can be quite severe. So it's very important that we monitor older adults for these 3 things regularly: medications, unsteadiness, and their blood pressure, especially doing it standing up, to make sure that they actually don't have low blood pressure when they stand up, if they're on medications that lower their blood pressure, and to actually prevent them from falling. Of course, as I mentioned earlier, there are lots and lots more reasons why older adults fall. And the other thing is that if you, as you can see, if you add a 4 out of 5 and 2 out of 3, and then the low blood pressure is also 2 out of 3, it adds up to more than 100%. It doesn't mean that older people multiply, but it means that these risk factors act synergistically, or they actually amplify each other, they coexist. So the risk of falls go up many times when you actually have more than one risk factor. So if you have if you're taking blood pressure medications, or you're taking medications that increases your risk of falls, and you suffer from low blood pressure, so dizziness, and then you suffer from imbalance problems, then the risk of falls multiply more than 3 times, many more times. So sometimes when we treat when we try and reduce the risk of falls, we might not be able to take away all the risk factors. So we just deal with the risk factors that we can deal with. And that will really markedly reduce the risks. So Shu-Hui mentioned the My Fate study. So the My Fate study stands for the Malaysian Falls Intervention Trial. So that was the first study that I conducted after coming back from Malaysia. So it started in 2012. And we got R1 million from our university to conduct this study because they felt that this was very important. And in fact, it's one of the only studies to be conducted in Asia and the only study to be conducted in Malaysia that looks at multifactorial intervention for falls prevention. So what do I mean by that? Okay, so first of all, we recruited people aged 65 and over. So that's what we call older. Because, this was an urban study, and 60 to 65 for the urban person is not that old. Yeah, so we started at 65. And then we chose the ones who have had 2 or more falls in the past 12 months, and then or 1 fall with injury. So the places we went to are primary care, so our RUCA building. So our research assistant June actually every day went to, those were the days before we had electronic notes, went to the clinic in the Rawatan Utama in UMMC and stuck a little note in front of all the patients' notes, asking the doctor to fill in whether the person has had 2 or more falls or 1 fall with injury in the past 12 months. And then they would take that little chit and post it in a little postbox that June sent with them. And in that chit, they will actually stick the patient sticker and put a contact number. So we will call those patients back to our clinic and invite them to actually take part in our study. So the other place we went to was emergency department, and they loved it. They always sent to us, and they were sent immediately because that was a way that they actually could discharge the patients and know that the patients will be followed up, and they were very interested in taking and in sending patients to our study. So what these older adults had then, because they've had 2 or more falls or 1 fall with injuries, that means they're very, very high risk of falls. If we actually assess 6 things. So what we did was we looked at the gait and balance, so whether they walked properly or whether they had poor balance. And then we also measured their blood pressure lying and standing. We assessed their medications, and then we also tested their eyes, and then we also referred them, if they've had a fall inside their own house, we referred them to our occupational therapist to do a home visit to actually look for what we call home hazards. And then we also gave them all education. So those were the ones who were actually randomized to the treatment arm. The control arm didn't get no treatment. They continued having the regular treatment that would be given to them in the normal clinic. And then if they had any of those problems, then if they had problems with walking or their balance, then they would have Otago exercises. So, and then the Otago exercises are basically done over 3 months. So they would come into the physiotherapy, to the physiotherapy gym. Physiotherapists will do an initial assessment, and then he will prescribe exercises appropriate to their level. And then they will be given a kind of homework. They'll be asked to do this exercise at least 5 times a week. And then they will have to fill in this diary to see how often they did it. And then they come back a month later, they got assessed. If they improved, then the intensity of the exercises will increase. And everyone got this for 3 months. And after that, they were told to join a regular exercise group, preferably a Tai Chi group or a gymnastics group in their local park, so to keep their fitness level up. Okay, and then the other thing that we did was if the occupational therapist went to their homes, so 1 in 3 actually fell at home, then they look for potential hazards that increases the risk of falls. And then they did really simple things like if the lighting on the stairs is not so good, ask them to change to energy saving bulbs. If the stairs contrast not very good, then they'll put these tiger stripes over it. And then getting rid of loose mats in the house, making sure the chair is not too low so they can get off, or not too high so they don't have to jump off. So those are very, very simple, low-cost intervention. We're not talking about renovating the whole house, but sometimes they need more things like grab bars, raised toilet seats, but not so common, but very, very simple things to be put in. And then we also, after the eye test, if they found anything wrong, then they also had cataract operations expedited if they had cataracts, or they had glasses made or changed. Some of them had irreversible eye problems, so but at least we know about it, and we can actually do things to actually improve the safety of the environment around them. We also had medication review. So if they were taking any medications that were potentially dangerous, they would actually have that changed as well. And then if they had low blood pressure, then they might have to have their medications changed if it was due to the medications. But if they weren't actually taking any medications and they still had low blood pressure, we would actually give them lifestyle advice, usually because they don't drink too much water, they don't drink enough water, or they have problems with their bladder. We can treat their bladder problems so that they will drink enough water after that. Okay, so that was the My Fate intervention. Then after My Fate, what we found was that we didn't manage to reduce the number of falls, because remember, I said people in Malaysia already fall less than the international contemporaries. So the reason why we had to do this study was to find out whether if we do such a thing, will we reduce fall or not? So the answer is no, we didn't reduce the risk of people falling. Maybe a little bit, but when we look at it statistically, we can't say that it didn't occur by chance. But what we did do was the people who had our intervention were stronger. Yeah, so they had better balance and stronger hand strengths. And then they also they were happier. So much lower rates of depression, much lower rates of anxiety, but they didn't fall less. So that led to the live study. And the life study basically was life after falls. So we hypothesized that why our fallers didn't fall less was our fallers didn't fall less after we did all this things to them, was because they were more confident, and so they continued being very physically active, whereas the ones who actually had normal treatment, didn't have all these exercises, didn't have the home hazards assessment, they had developed fear of falling, so they stopped going out, they stopped being physically active. So the live study actually intended to look at their psychological status after a fall, and also the physical activity, and link that to blood pressure variations and also the home environment. But as life would have it, the pandemic hit. And so we had to really pivot our study. But as they say, with every challenge comes great opportunity. So while we couldn't complete the live study, we were able to write to our funders and say, we have issues. These are fallers, these are frail older adults. They're not going to come to the clinic. The COVID pandemic is there. You're not even allowed them out the house. And how do we do exercise therapy and things like that? So, but we would like to take this opportunity to pivot to virtual assessments. So we're not wasting your funding. And that therefore was born virtual falls assessment. So we were able to find tools that will allow us to do assessment on their mobility by just asking a few questions. We were still able to test their memory. And a lot of people actually own blood pressure machines at home. So we were able to direct them and observe them to do blood pressure lying down and standing up with the help of another person at home. But if they didn't have a blood pressure machine, we actually had a questionnaire to find out whether they could have low blood pressure when they get up too quickly. And then we also tested the psychological health. And because it was done during the pandemic, what was very important was whether they were still socially active. Because otherwise, because social isolation is actually one of the main reasons why older adults fall. Because if you socially isolated, you don't eat, you tend not to eat as well, you tend not to exercise, and you tend to have more problems with depression, which then increases your risk of falls. Okay, so Shui also mentioned the World Falls Guidelines. So this is what we call it an algorithm. You know, if you imagine a computer, you can actually set them to do this algorithm. So we're treating doctors like computers now, but the whole point of this is actually getting everyone in the world to actually standardize how they approach a fall. So if I go to a doctor in Canada, if I go to a doctor in Australia, or they will do the same thing. It's standardized. It's because we have a global community now. So we can accelerate the falls prevention efforts internationally by getting everyone to standardize their practices. So of course, the World Falls Guidelines took many, many years to develop, and it covered a lot of areas. But what was perhaps the most important bit was to standardize how the healthcare professional approaches fall prevention in the older adults. So in this algorithm, I'll take you through it. This is very fun because it's all animated. So what we have is two entry points. Okay, there we go. Two entry points. So the first entry point is we're asking every healthcare professional who encounters a doctor, a older adult, so anyone over the age of 60 for Malaysia, and any developing country, but over 65 for a developed country, to ask them whether they have fallen in the past year or not. Okay, so if they've had a fall in the past 12 months, if they haven't had a fall in the past 12 months, then they would be considered low risk of falling. So what we then do, if you haven't fallen, then the preventive approach would be primary. So that means that we want to stop you falling even for the first time. So this would be an opportunity, since we already brought up the information about falls, to actually give them a bit of education on falls prevention. So maybe providing a leaflet or just having a chat to ensure that they do enough physical exercise to make sure their muscles are strong, and that if they're on medications, that they're reviewed regularly, and then they are aware of home safety, etc. Okay, so and then the plan would be to ensure that there's another encounter in a year's time where they are asked the same question. Okay, so if they say, yes, I have fallen in the past 12 months, then you need to do a gait and balance assessment. So how they propose we do this is using a test that needs minimal training. So it can be done by an attendant in the clinic, can be done by a trained person. Doesn't need to be a healthcare professional. So we test their gait speed. So in the Western countries, they have very fancy gait speed machines. You know, they have this. It's like the tracker that they have in a 100-meter track. And just go follow the patient. But in our clinic, what we do is we have a 10-meter walkway, and then we stick markers at 2 meters and 8 meters. Then we get the person to start walking at their normal speed, using, if they need a stick, if they normally use a stick, they should use a stick, and the usual footwear. Yeah. So, but if they're wearing high heels, maybe we actually get them to, we actually might ask them to take off their shoes, because we just don't like people on high heels. So, but anyway, so when they cross the first line, so the 2-meter line, we start timing. And then we ask them not to stop and go straight past the 8-meter line until they get to the 10-meter until they get to 10 meters. We just basically capture the speed they took to go from the 2-meter line to the 8-meter line. And then, so how many seconds is that? And we do 6 divided the number of seconds it took to actually cover that distance. And that would be their gait speed. Now, when we did this, we had this group that were from Brazil, Colombia, and Malaysia. And we went, you know what? I don't think many of our clinics have a 10-meter walkway. There is no 10 meters for them to walk. So we found so on our petition, they actually also agreed to include the time up and go test. So that's a test that we advocate for every clinic that sees older adults, and can be done very easily. All you need is a chair. And then a lot of times they put a cone about 3 meters away from the 3 meters away from the front leg of the chair, or we just put a little marker there. We get the older person to sit properly in the chair, and then when we ask them to get up, walk that 3 meters, turn around, walk back and sit back down again. And the time for them to from the bottom leaving the chair until the bottom hitting the chair once more should not be any more than 15 seconds. If that exceeds 15 seconds, then they are at increased risk of falls. So let's say that it's less than 15 seconds, then they are low risk again. So you go through the same thing as, because you're allowed to fall once a year, it might be an accident. Then we go through the same thing as the low risk people. We give them a bit of education and arrange for another encounter in a year's time. So but if they have had a gait and balance problem, so the time up and go is abnormal, but they've only fallen once, then we will actually put them in intermediate risk group. And these people need tailored exercises. So they should ideally go and see a physiotherapist. In a country like Malaysia, there isn't actually a good reason why anyone shouldn't see a physiotherapist, because physiotherapy is easily accessible. For those who have affordability issues, they can be accessed through the government health services for free, because all older adults over the age of 60 will be able to access free healthcare. But if you, but of course, it is a bit crowded, there's long waits. So you can actually access private physiotherapy or home-based physiotherapy for reasonable prices. So you don't always have to rely on free services by the government. And of course, we never forget the chance of giving them some education. Now, but the group that we're most interested in is a group that the group that has the same measure of risks as, oops, sorry, it's the same measure of risks as the people that were included in the MyFate study. So in the MyFate study, remember we said 2 or more falls in the past year or fall with injury. But when we discuss the work guidelines, we actually asked that they also included people who looked very frail, who were lying on the floor and unable to get up, or we think might have blacked out, might have lost consciousness. Okay, and this group of people often also pitch up in our emergency department or in a clinic after a fall because they would have fractured, or they would have needed, they would have cut themselves and needed stitches, or badly bruised themselves or knocked their heads. So we can capture these people from hospitals quite regularly, or even clinics, because they actually come with their falls. And then if this group are at high risk of falling again, and the fall is likely to result in something serious. Okay, so what we do is we actually look at secondary prevention and treatment, because they've already fallen, and we actually do the multifactorial false risk assessment and the individualized tailored intervention that we discussed in the MyFate study. And it's important then to see them depending on how busy your clinic is in 1 to 3 months to make sure that they have got better and they're following the treatment that you give them. Okay, so and the other thing that, of course, this algorithm has done is help us define what's a low risk fall, what is an intermediate fall, and what's a high risk fall. And we also actually then also have this criteria for severe falls, which is falls with injury, 2 or more falls, for a frailty, lying on the floor, unable to get up, and loss of consciousness. Okay, so so that is pretty much what I have to share with everyone today. And this is the I'd also like to take this opportunity to share some information about a fall prevention course. So this is targeted to healthcare professionals, okay? And what we intend to do is to actually train as many people in the country as possible in falls prevention. So the price is not very high, but it's a little bit high because it's very, very personalized, hands-on. You get very so that you, after this course, you are actually equipped in managing falls. But and we do hope that if you're a healthcare professional or a physical trainer, that you would actually consider joining us in this course so that you can actually contribute towards the army of people that we are hoping to develop to actually help prevent falls in older adults. So thank you very much again to Angsana for this opportunity. And I have left lots of time for questions. But if there is no questions, then we will actually
Have some
um
questions.
we will actually then we actually have a discussion and a chit chat. Okay, thank you.
Thank you, Prof. Tan. Thank you very much for sharing all the information. It is very helpful. Like you said, everyone as a community, we should help prevent falls among older adults. I think we will start with the question asked by our audience first, and then if we have time, then maybe we can discuss a little bit more things outside this question. So the
Okay.
first question is, what is the most common combination of medication which result in a high risk factor for fall among older adults? What kind of combination of medication?
Okay, that's a really interesting question. Okay, so unfortunately, if we know exactly the reason, then we wouldn't give the medication, right? Which doctor will give you a medication that they know is going to lead to a fall? So we do try and educate all our doctors to say when you prescribe medication to older adults, you need to make sure that they are not at high risk of falls. If they're at high risk of falls, you perhaps want to actually avoid these medications. So all medications, ideally, we believe is actually prescribed by your doctors in good faith. So, but sometimes we can't predict. So sometimes people will have a side effect to that medications. We knew we wouldn't have given it to you, and that will increase the risk of falls. So the medications that commonly cause side effects when it comes to falls are medications that work on the brain itself. So the most dangerous medications when it comes to falls that we actually want to avoid in older adults are sleeping pills. So I'm sure you find it very difficult to get sleeping pills nowadays because your doctor don't want to prescribe it. So that is quite common. And often people with sleeping pills also have maybe problems with depression or other psychiatric illness. So those drugs, psychiatric illness have to work on the brain, no choice. And the doctor will not prescribe it unless you need it. So please don't stop the medications yourself. If you've fallen, go back and see your doctor and they will decide whether they can actually change the dosage or switch the medication or whether you really no longer need it and they can stop it. But so the idea is not to be your own doctor, but to as soon as you expect, I know the time when you're most likely to fall is when you first start the medication. Then that increases your risk of falls. The other thing is when you're well, you don't fall, But if you are actually when you're ill, so when you have a cold or a flu, then normally you don't react to that medication, but suddenly you have a cold or flu, you're a bit dehydrated, and maybe the medication then if you take blood pressure medication, your blood pressure might be too low at that time. So you might want to see the doctor, and the doctor might ask you to stop the medication temporarily until you recover and then re-challenge you once you've made a full recovery. So that might happen also. And then next time the doctor will say, when you're sick and you tend to drop your blood pressure, maybe you should check your blood pressure more often when you take this medication. So those are things that you can do, but don't believe that doctors give you medications with the intention of causing falls, because that will never happen.
Yeah. Thank you, Prof. I think related to the first question, I think people are also curious, what is the benchmark for low blood pressure for older adults? Like what is the benchmark? Let's say if they check at home, I believe that's the reason this question is asked.
Okay, that's a really, really good question. In fact, I have so many patients who check their blood pressure at home and then they hide the reading from the doctor. That's really funny. I don't know why they won't tell me what their measurement is at home. And then the other thing that they do is they don't actually know what is normal. So, okay, and the answer is it's not so straightforward. You need to ask your doctor when you take your blood pressure treatment what your target should be. Because normal is different for everyone, because it depends on your risk of heart problems, your risk of strokes, and also it depends on your age and overall what other medications you're on. For my patients, older adults that I see who perhaps balance is not so good, I sometimes say to them, try to keep your blood pressure above 140. because we think that that's the safest level for you. Yeah. But then there are people who have had a stroke and they have diabetes, and the doctor might say keep it as low as possible, preferably below 120. So you need to talk to your doctor and get them to give you a clear idea of what your target should be. So I hope that answers the question. Not so straightforward, right? That's why you have doctors. Otherwise, you can be your own doctor already.
Yeah. Thank you, Prof. I think the next question, I'll just combine two questions into one.
Mhm.
Because it is actually because I think the reason people are curious how is because everyone has got different kind of medical condition. So
Yes.
for there's one example given is somebody who has got Parkinson's, but
Mhm.
no dementia. Very difficult to bring for physio. That's scenario number one.
Yes.
Another is somebody who had a stroke or like osteoarthritis, sorry. So how do they approach this, and what can they do to reduce risk of falls?
Okay. So as these are very, very, very good questions. And these are questions that false experts have been asking for a very long time. So no two-person is different. So we're talking about hypothetical situation. Now, both stroke and Parkinson's are very strong risk factors for fall. So if you have Parkinson's disease or if you've had a stroke, then your risk of actually experiencing a fall in the next year is double or treble or quadruple that of someone who hasn't got Parkinson's or stroke, especially Parkinson's disease. We call it the falling disease. But no two people who fall because if they have Parkinson's disease, and no two people who fall even if they've had a stroke fall for the same reason. So what you really need to do is you need to see your regular doctor who treats your stroke or your Parkinson's disease to tell them that they've fallen. And they might know straight away what it is because they might have started you on a new medication that increases the risk of falls. But sometimes they need help from the falls specialist, so they send to me in the falls clinic for further assessment. And what do we look for? So it doesn't mean that you've got Parkinson's, you'll be falling exactly because of this Parkinson's. But Parkinson's have lots of complications. Treatment for Parkinson's also have complications. But you need it because without the medications, you can't move. So one of the biggest causes of falls in people with Parkinson's is actually their medications, because their medications can make their blood pressure drop when they stand up too quickly, but it can also make them a little bit confused. So sometimes we can just sort it out by tweaking the medications. So then no need to come to physio, no need to worry about having to come to physio. But actually, right, Parkinson's disease, physio is a very, very, very good treatment. And the thing is that physiotherapy coming to clinic is not coming to physiotherapy sessions is not to a hospital may not actually be the best way to manage the person, especially if coming to hospital is so challenging. It's a three-man job. It takes an army, right, to get an older person to hospital sometimes. So someone to drive and park the car, someone and then two people to help them out of the car. They want to push and want to pay the bills and collect the medications and those things. So it takes an army to get an older person to hospital, because our environment in hospital, even though it's for sick people, is not really that conducive. So what you could do as an alternative is get physiotherapy done at home. And previously, physiotherapy at home means having a physiotherapy come to your house to do it one at a time. But now we actually, with virtual technology, we can engage on virtual physiotherapy. So even during the pandemic, we had to do that. So a friend of mine who lives in, whose parent lives in Sungai Petani rang me and said, "Oh, my parent has had a fall. My mom has had a fall." So I went, "Sungai Petani got physio or not?" She went, "No lah." So then, so we actually did virtual with physiotherapy from PJ to Sungai Petani during the pandemic. Then after the pandemic, we went, oh, if they can do physio like that, during the pandemic, why can't we do it after the pandemic? So actually, now with virtual technology, there are lots of other options other than having to bring the older adult who has mobility problems to hospital. And then there are somewhere in between where you can go to a center nearer your home, a physio center near their home, so that they can ideally have group physiotherapy rather than one-to-one sessions. Group sessions are more economical, but hopefully those services will evolve over time. But what we really need is people to not say, yeah, cannot, too difficult, don't want to do. So if we have more and more people buying into these sort of treatment, they actually save money in the long run. Because if the older person is more mobile, more capable, then they're less likely to need you're less likely to have to pay for them to go to hospital. If they don't fall, then they don't break bones and you don't have to pay for operations. Then it actually saves money in the long run. But we have to persuade people that this sort of investment is worthwhile.
Yeah.
Okay, osteoarthritis. We hadn't covered that yet. So we actually specifically looked at the osteoarthritis group. Why? Because Malaysians are very funny, Even though they fall a bit less, a lot of them have osteoarthritis one. And when we look at the world map, right, Malaysia as a population, right, has more knee osteoarthritis than other Western populations. It's just our makeup makes us very likely to get knee osteoarthritis. Maybe our lifestyle, we do a lot of kneeling, we sit on the floor a lot, and then maybe a lot of about obesity issues. Obesity actually increases the risk of knee osteoarthritis. And basically, the best treatment for arthritis is exercise. Yeah, it actually is the best treatment for the pain from osteoarthritis. And so when we did this My Fate study, we actually have a special osteoarthritis sub-study, and we found that the Otago exercises is safe in people living with osteoarthritis. And they are able to do it, and it improves the osteoarthritis symptoms and also reduces their risk of falls and make them stronger and more mobile.
Yeah.
And less depressed.
Yeah, thank you, Prof. Actually, you have answered one of our audience query as well, because he or she was asking whether the Otago exercise that you mentioned just now can be done at home. And the answer is yes, if you have a virtual physiotherapist to guide you through the whole process.
Yeah. But actually, Otago exercises is done at home, even from the start when we developed it, because we do know how difficult it is for the older adult to come to the clinic to do the exercises. So to expect them to come 5 times a week, forget it, man. It's not going to happen. So we actually made them come once a month, and then the rest of the time they exercise at home. They only come for the exercise prescription. So they do the exercise at home anyway. But now with virtual technology, they will never even have to come to the physiotherapy clinic. They just get it prescribed at home and they do it at home. Yes.
Yeah. One question that I got was if somebody has got osteoporosis, so they were told by their doctors that they have osteoporosis, can they still do Otago exercise?
Oh, Otago is designed specifically for these people, because remember, Otago is designed for fallers. And it's the first time we find out someone has fallen is often when they turn up to the hospital with a fracture. So these people already have osteoporosis. So Otago is specifically designed for people with osteoporosis. So exercises to avoid if you got severe osteoporosis is to actually avoid jumping. So high impact exercises, because they might actually lead to fracture. But otherwise, having some if you have, particularly if you were trying to prevent osteoporosis because your family history, and also you're very thin, and also you have lots of allergies, so you don't drink much milk, then your risk of osteoporosis is much higher. And also if you have osteopenia, thinning of the bones, we actually encourage people to do exercises that are weight bearing. Yeah, so it depends on how severe your osteoarthritis is, because it's very, very thin. Then doing those kind of high impact exercises could lead to fractures. But for those people with mild osteoporosis, having some weight bearing exercises is exactly what they need to build the bones. Because if you don't use weight bearing, the bones are not going to actually grow stronger. So exercise is also a treatment for osteoporosis, and the treatment is weight-bearing exercises.
Thank you, Prof. I think we have gone through quite a number of things. Just in because it seems a bit complicated for some caretakers, and some may feel that the best way is actually to refer to a doctor or a specialist. during your presentation just now, you did mention a few things that caretakers and seniors, older adults can do at home. And I'm just wondering if you have like 5 things that you can tell the caretakers or seniors at home. What can they do to prevent fall? What would be the 5 things that you tell them to?
Okay, so this is part of the falls prevention education. But remembering that if the older adult has already fallen, then they don't need and they've only fallen once, then they might not need to see a doctor. So that's what we're trying to do to reduce the need for everybody come to see doctor just because they've fallen once. Could you imagine the number of people who've fallen is so big? So then if they all come and see a doctor, we don't then nobody else will get to see the doctor already. So if they've fallen just once, we're actually asking the healthcare professional who sees them. It might be a physiotherapist, it might be a nurse in the clinic to test their walking balance, and their walking and balance. And if that is normal, they don't have to come and see the doctor. They just need to be given advice on how to stop themselves falling. Because it might be that they do some very dangerous things like, don't turn the lights on when they go to the toilet and they trip over their pet or something like that. Yeah, funny things happen, that's why falls can be very comical. And that's what keeps me going now, because some of the circumstances that my patients fall, you're also like, why did you do that? Huh? But the other thing that they might detect is if they've fallen just once, then they have balance issues, then they should have physiotherapist. So you don't have to come and see a doctor. All you need to do is see a physiotherapist. But if they've fallen twice or more, or if they're frail, then and they've had one fall and they look very frail, or they've had potentially blacked out when they've fallen, or they've fallen and they've injured themselves, or they've fallen and they cannot get up, then those are the ones who have to go and see a doctor. Yeah, and have a specialist input, because those people very high risk already. So next time they fall might be when they break something, and break a big bone like the hip, and that will be really difficult for the older adult to recover from. So those people don't play, must go and see a specialist. Yeah. So the other thing is that your home environment must always be kept safe. So as Asians, we like to walk with bare foot, but the floor must be shiny. We don't like shiny floors. Okay, shiny floors are slippery floors. So we need to reassess the flooring that we tend to put in our own houses. So tiles are very bad for falls, because when you mop the floor, it's wet and then you're risk of falls. But of course, changing the flooring for a lot of people can be too costly. So if you were thinking of new flooring, please don't put tiles on if you got old people on. Wooden flooring is better. Yeah. And we like carpet, but a lot of Malaysians don't like carpet because they think it's dirty. So compromise would be wooden flooring. If you have to have tiles and you've already got tiles, then make sure that if the floor is wet, that you actually notify people that the floor is wet and they're not supposed to walk until it dries. And then preferably wear shoes in the house. I know, but indoor shoes, because then you have better grip in the house. Don't wear bata slippers. If you're going to, there are specific types of slippers that slip-on shoes that is more convenient to be worn in the house, and that will actually potentially reduce the risk of falls. The other thing that people like to do is the bathroom. Bathroom are always wet in Malaysia, man. Always wet. So we need to make sure the bathroom is dry. And in the bathroom, you need to make sure the tiling that you have in your bathroom is non-slip. But if you in a shower, you can put non-slip the non-slip mats, and then you must also people like to put a towel outside the bathroom to wipe their feet. So those have to have the bath mats, the mats that you put outside the toilet to wipe your feet needs to have a non-slip surface underneath it so that it grips onto the flooring so that they don't slip. And then stairwells need to be well lit. And then by the bedside, they need to have a lamp. Yeah. So so those are things that you can do to help the home environment stay safe. Yeah.
Yeah. Yeah. Thank you, Prof. I think we have time for at least 2 more questions. So this is a question from somebody who is caring for an elder person at home,
Yeah.
because you mentioned that exercise is good for muscle strengthening in preventing falls, but it's challenging to get them to do exercise because they are afraid of falling. So do you have any tips or practical ways to help sort of improve this confidence to do physical activities and exercises for this specific group of people?
Okay, that's a very, very important question.
Yeah.
And basically, fear of falling is a very challenging area.
Yeah.
So, one thing we have to remember is having a little bit of fear of falling is actually good, because people are more vigilant, right? So they're more going to take care better. So that's supposed to be a defense mechanism. After a fall, you're a little bit scared of falling, so that so you're more careful and you're less likely to fall again. But the people that we have problems with are those, we call it pathological fear of falling. So the fear of falling is so severe, they don't want to go out, they don't want to do anything. And those are very, very challenging. Okay, so I see a lot of them, and I have to spend a lot of time with them to talk to them to actually help them gain confidence. So one of the things that you must know is you can't make people exercise one, because if they don't want to move, you can't make them move. So sometimes people with fear of falling can be so bad that they've developed depression, and then they're undermotivated. So you might have to treat that. And then you might have to set little goals with them, to say, maybe we will work on you just getting out at least one or twice a week, and then you choose safe places to go through to, like like shopping centers are actually very good places and safe places for older people to walk at, rather than the park. Yeah, so that they're more willing to go out. And the exercises that we like people to do when they've fallen, don't involve walking one, because walking is actually not so. It's actually one of those things that lead to a fall. If you don't walk, you don't fall. So we actually get them to really concentrate on muscle strengthening exercises. So those are exercises that they will do, and they won't feel afraid of falling, because they're just strengthening their muscles, and you might want to go to a gym with them. So don't take them to a gym, but go to the gym with them. So you empower them, and then they will actually do some weight training to improve their muscle strength. And then for balance exercise, you stand still and then do things that challenge their balance increasingly, and that will actually help them regain their confidence. But the main thing is, don't nag lah. Yeah, and because that will actually make it a fixation, isn't it? Whereas, but reward anything that they do that is encouraging, that is more useful.
Use positive reinforcement.
Yeah, that's
And
right.
when they go out, and then we try and encourage them, and I
Yeah, yeah,
think
yeah, yeah.
being with them and doing it with them might be helpful for
Yes.
situations as such. I have one question. This is coming from a healthcare professional's
Mhm.
perspective. For high risk elderly people who have fallen more than once, um, the question is it recommended to see a geriatrician for fall risk assessment, or an orthopedic?
Okay, the orthopedic will refer to a geriatrician, because the orthopedic's job is to mend bones. So you actually need a physician to do this job, because we assess medications, we assess medications, we assess muscle strength, we assess memory, we assess vision. So you actually need a physician for this job, and preferably one who have been trained to look after older adults. Now, there comes the problem. If you live in the Klang Valley, by and large, you can access a geriatrician, but it still takes time, long waiting lists. So what we're trying to do is work with general practitioners and also primary care family medicine doctors, to try and get them to come up with services so that people can have false assessment without having to find a geriatrician. But the orthopedic surgeons are not really trained to do false risk assessments. They're trained to patch you up if you've broken a bone. Yeah.
Yep. And very last question. I think this is the very last, and after that we will have to close. If somebody has got a normal calcium level, should doctors still give or should seniors still take calcium supplements?
Okay, that's a really good question. Yeah,
Mm,
so basically, we do no longer recommend blanket replacement with calcium, because we do find that it seems to increase the calcification of their blood vessels. So yeah, so we only recommend a calcium supplementation to those people who do not have enough calcium intake. Now, that is not necessarily reflected on the blood test, because for the blood test to be very abnormal, you have to have very severe, to appear as abnormal, you have to have very severe calcium deficiency. So osteomalacia already before you can see an abnormal calcium on the blood test. But what is more important is vitamin D.
mm,
So vitamin D is what we need to absorb calcium. So at one stage we used to put everyone on vitamin D. But the more recent study shows that if we measure your vitamin level, with vitamin D level, and your vitamin D level is normal, if you're a faller and give you vitamin D, then that adds to the number of medications you're taking. So the risk of falls actually goes up a bit. So if you're a faller, we only give vitamin D supplementation if you actually have proven vitamin D deficiency. And as I just repeat myself, calcium, if you do not have enough calcium intake, so like you don't like to drink milk, because you've got a milk allergy, a lot of Malaysians do, and your diet is a bit restrictive, then it's necessary for you to take calcium supplementation.
thank you. Um, I think we are almost time now, so I will wrap up today's session. I think we managed to answer most of the questions given by our audience. So thank you very much, Prof. Tan, for your insights and guidance throughout today's discussion on falls prevention and healthy aging. I'm just gonna quickly share a little bit about some of the services for risk assessment can also be done on online through Angsana Health. So if you have got any interest in it, please feel free to sign to just scan this QR code, and then you can get more information about these services. So I thank everyone for your engagement and for your time. I think it's very important that healthcare professionals and caretakers just even individual seniors are aware of the risk factors for falls and how best to avoid them. So I think that's the end. Prof. Tan, do you have anything else you would like to tell our audience before we close this call webinar tonight?
Okay, so no, don't blame adult children for their parents falling. And falls is not just about balance.
Hmm. Yeah, that's very true. Yeah, I hope we'll carry forward the knowledge and all the strategies shared here into our patients' life, our homes even, and also our community, so that we all can take part in promoting more active aging for our Malaysian seniors. So thank you everyone for your participation and your time. I hope you have a wonderful evening ahead. Okay, thank you. Bye.
Bye, everyone. Bye.
Thank you, Prof.
Thank you. Bye.